Thank you, Priya. Thank you all the participants for joining us. As she mentioned, today's session is important because we understand some of you are already using opioids, and many of you do not have access to opioids or have not used opioids yet. But in many a times, especially most specifically in cancer pain, it plays a major role in managing pain. So this is going to be a very important session, and I'm sure Dr. Sunil will have a lot of real life case scenarios to share with you and hear back from your own experience also. Thank you so much, Dr. Sunil, and over to you for the session.
Thank you, Sridevi, Sripriya, and good afternoon, everybody. So I am going to my presentation straight away. Sorry, I will be talking only on opioids because non-opioids was already covered yesterday. But before going on to the topic as such, I just want you to understand this. This would be a vision for you. So in the WHO analgesic ladder, we have three groups of medication. One is non-opioids, and the other one is adjuncts, and the last one is opioids. So the non-opioids, it includes paracetamol and other NSAIDs, and many of you might be using many NSAIDs. In addition to this, that is given here, there are many. So then we adjuncts. What is an adjunct? Adjunct is a medication whose primary action is not pain relief. So those medications whose primary action is not pain relief, but is helpful in some painful condition. That is known as adjunct analgesics. So tricyclic antidepressants, the primary action is antidepressant action, but it is helpful to treat neuropathic pain. That's how it becomes adjunct analgesics. Likewise, SNRIs, serotonin and noradrenaline reuptake inhibitors like duloxetine, venlafaxine, anticonvulsants, anticholinergics, corticosteroids, and methyl diaspartate antagonists like ketamine, muscle relaxants. So those all are adjuncts. And in the opioids, in India, these are the main opioids that we use for chronic pain management. So you can see there is codeine, dextropropoxyphene, tramadol, tapentadol, morphine, fentanyl, and methadone. Okay. So with this, I would like you to read this patient story. So we have a 35-year-old man who is a father of two young kids, and he is diagnosed with carcinoma of the upper lobe of right lung, and he is complaining of deep-seated throbbing pain over right suprascapular and infraclavicular area, and the pain score is 3 by 10, which he described as continuous pain, and he is unable to sleep at night. So how are you going to manage his pain? So first of all, we have to understand what is the type of pain. So what is the type of pain? Is it nociceptive or neuropathic? Anybody, you can unmute and speak, or you can give your answers in the chat. Okay, Dr. Pratiksha says neuropathic. Anybody else? Nociceptive. Yeah. It's mostly nociceptive because it says throbbing and it is not restricted to a neurodermatomal area. So what are the features of neuropathic pain? Neuropathic pain, there are four features. One is you should get a history of a lesion or disease affecting somatosensory nervous system. So you should be able to elicit a history which is affecting somatosensory nervous system. Then it is neurodermatomal in pattern. Neuropathic pain is always neurodermatomal. So the specific area supplied by the nerve would be affected. Then the quality of pain. Quality usually it's burning, stabbing, uh, electric shock like lightning, all are the descriptions of neuropathic pain. Then fourth character is abnormal sensations. The abnormal sensation can either be increased sensation or it can be decreased sensation. So the examples of increased sensation are allodynia and hyperalgesia. Whereas examples of decreased sensation is numbness. Some patients may tell you that whenever I touch this area, I do not feel, but I have severe pain in this area. So that means it's a neuropathic pain. But here it's mostly continuous and throbbing pain, which is characteristics of nociceptive pain. Okay. So the patient's pain score is 3 by 10. And so how would you manage his pain? If you want to speak, please unmute and speak.
So actually, I had a doubt. So could you explain a little bit more about what you mean by eliciting history for neuropathic pain?
Not very clear, Dr. Abraham.
So could you explain a little bit more about what history we elicit, which is typical for neuropathic pain?
Repeating the characters of neuropathic pain.
Yes, sir.
Okay. So one is that you should get a history suggestive of a lesion or disease affecting somatosensory nervous system. So suppose a patient gives you a history of herpes zoster in the past. That means that is a history suggestive of a disease affecting somatosensory nervous system. That was the first point. Second point is it is neurodermatomal in distribution. So suppose that herpes zoster affects T4 nerve, then the pain would be in the area of T4 distribution. So that is neurodermatomal distribution. The third point is it is abnormal sensations. The abnormal sensation can either be increased sensation or it can be decreased sensation. Increased sensation examples are allodynia and hyperalgesia. And decreased sensation example is numbness. Then fourth one is quality of pain. Usually they talk it as burning pain, electric shock like pain. So these are the four characters of neuropathic pain. Yeah, and I can see some responses. Paracetamol, start with paracetamol or NSAID and observe. Fentanyl patch, okay, NSAIDs. Okay. So, how do you select which step of WHO analgesic ladder you need for treating a patient? It is according to the severity of the pain. So the first step is for treating mild pain. So you can say core 1, 2, 3 is mild pain. Second step is for treating moderate pain. That is 4, 5, and 6. Then third step is for treating severe pain. 7, 8, 9, and 10. Okay. So what is the pain score here? It is 3 by 10. So you can use paracetamol or NSAID or even both. Okay. So this patient, they have started him on paracetamol 750 milligram, 6 hourly, ibuprofen 400 milligram TID, and pantoprazole 40 milligram once daily. But the patient says, I have still pain and it is not satisfactory for me. So how do you proceed now? What are you going to do now?
So we will give combination drug.
Yeah. Which one do you want to give?
Combination drug. Paracetamol with Panadol.
Okay. Very good. But can anybody tell me what is the limitation of combining two drugs? What would be the limitation here?
We should reduce the dose.
Sorry.
We should reduce the dose.
Yeah. Maybe, but
Dosages
there
are
is,
fixed.
yeah.
So the dosages will be fixed. We cannot modify it according to the patient's requirements.
Yeah, please look at the tramadol paracetamol combination, which is one item is
Half-life will be different, no?
the
I mean, duration of action of each would be different.
dose of paracetamol required for pain relief is something which we need to understand. In the combination, the dose of paracetamol is only 325 milligram. So, what you will achieve with 325 milligram of paracetamol? It is not going to be beneficial. So, and if you want to give more paracetamol, you have to give more tramadol also. So that may cause more toxicity. So combinations are always not very good, especially when you look at what should be the maximum dose of each medication that need to be given for patient. Okay, so for this patient, he does not have proper pain relief. So how do you go now? You have to step up. Don't go in the same step, increasing the dose, increasing the paracetamol dose or increasing the NSAID dose or changing over to another NSAID. That would not be effective. You have to go up. So what are you going to give for this patient?
Opioid, sir. Opioid.
Yeah. Yeah, I see that consider morphine, add tramadol, consider fentanyl patch, add weak opioid. So what is the next step? We are in step 1, isn't it? Non-opioid plus or minus adjuvant. Here we are giving only non-opioid. What is the next step? Second step of the
Adjunct.
analgesic ladder?
Adjunct.
It is opioids for mild to moderate pain, plus or minus non-opioid, plus or minus adjuvant. So what are the opioids that is used to treat mild to moderate pain? Which are opioids? And some people say weak opioid. Yeah. I'm asking, what, can you name a few weak opioids?
Tramadol.
Yes. Anything else? Yeah. So yes. So usually use this tramadol, tapentadol, but codeine and dextropropoxyphene are also opioids for mild to moderate pain. Okay. So you need to step up to either tramadol, tapentadol, codeine, or dextropropoxyphene. So what are the few things that you need to be aware about tramadol? Tramadol has dual mechanism action. It acts on opioid receptors. It also inhibits the reuptake of serotonin and noradrenaline. So which group of medication has this action? Inhibition of reuptake of noradrenaline and serotonin?
Carbamazepine. Carbamazepine.
Carbamazepine is an anticonvulsant.
Yes.
SNRI, sir.
Yeah,
It reduces analgesic effect.
tricyclic antidepressants. Okay, so tramadol has dual mechanism action. It acts on opioid receptors as well as it acts like tricyclic antidepressant. And when we talk about opioids, we always compare the potency of an opioid with that of morphine. Okay, so how much potent is this drug compared to morphine? So, in other words, what is the weight of this medication required to get the same pain relief that is obtained by using 1 milligram of morphine. So what is the potency of tramadol? It is 1 by 10. That means 10 milligram of tramadol is equal to 1 milligram of morphine. And another important thing is that morphine reduces the seizure, tramadol reduces the seizure threshold. So tramadol should be used cautiously in patients who has epilepsy or who are prone to have seizures, like patients with brain metastasis or any other medications which can reduce the seizure threshold, like antipsychotics, tricyclic antidepressants. All these medications can actually reduce the seizure threshold, but especially if possible, you should not use it in patients who has epilepsy. And the maximum recommended dose is only 400 milligrams per day. And tapentadol is the brother of tramadol, younger brother of tramadol. And you can see that it is almost normal, it is almost the same, both medications, but potency of tapentadol is little more compared to tramadol. It is 50 milligram of tapentadol is equal to 15 milligram of morphine. And they say drug interactions are less. So next is we have Mr. P, who is a 70-year-old man with carcinoma of the lung and is complaining of throbbing pain on right front of chest, which is continuous and scores 5 by 10. He is a non-epileptic and is on levetiracetam 500 milligram BD. How are you going to manage his pain? Which medication would you use? What is the pain score? It is 5 by 10. So then we have to use which step of WH analgesic ladder?
Opioids.
Yeah. Which step? Which step of WH analgesic ladder?
Step 3.
Step 3. Is it severe
Okay.
pain? It is not severe, isn't it? 4, 5, 6. It is moderate. So you have to use second step of analgesic ladder. Okay. So which one would you use? Which medication would you use here?
Tapentadol.
Sorry, couldn't hear Dr. Ruji.
Tramadol, we can't use, it reduces the seizure
Yeah.
thresholds. I was
Yeah.
saying tapentadol.
Tramadol and tapentadol should not be used.
Both should not be.
Both should not be
Then
used.
morphine. Then morphine.
Yeah. Codeine and dextropropoxyphene are the choices, but nowadays nobody uses codeine and dextropropoxyphene. So even low dose morphine could be an option here. So something about morphine, codeine, it is 1 by 10 as potency of morphine. So 10 milligram of codeine is equal to 1 milligram of morphine. And main metabolite is codeine 6 glucuronide, which is metabolized by cytochrome P2D6 enzyme. So this cytochrome, even tramadol is metabolized by the same enzyme, cytochrome P2D6. And there are genetic variations in the Asian population. So that some people may not be a metabolizer of tramadol or codeine, and they may not have pain relief at all. So this is something which you need to keep in your mind. And codeine is a prodrug of morphine. That means codeine will be later converted to morphine and its metabolite. And it acts by 30 to 60 minutes. Duration of action is 4 to 6 hours. And many of you might be using codeine for pain relief, but mostly general practitioners use it for as a cough suppressant as well as an anti-diarrheal agent. Dextropropoxine, actually this was the weak opioid or the opioid from the second step, which was used very commonly before 2014 or 15. But after that, its use has suspended in India. But now it has come back into the market. And the principal metabolite is norpropoxine, and it accumulates in renal failure. That's another issue. So that you should not use it in chronic kidney disease or patients who are elderly. And you can see the indication. This is the order which says it should be used only for cancer pain, and daily administered dose should not exceed 300 milligram per day. So I don't know. Any of you use dextropropoxine nowadays? Codeine is not available in a regular market. It would not be available from a pharmacy. It would be available only from a recognized medical institution. So this recognized medical institution status will be obtained for institutions where there is a doctor who has at least 10 days of experience in pain management, and the drug controller has provided you with the RMI status. In such institutions, there will be codeine, but otherwise codeine would not be available. Okay, please see this patient. What is his problem? He is in severe pain. Okay, you can see his facial expression. He came to us with severe pain. And you can see after 30-40 minutes, he is smiling at us. So, what is the magic behind this? Anybody? Morphine. Yeah, Dr. Weiss, Herman says morphine. Yeah. So this patient, he's a 54-year-old man with carcinoma of the larynx, who came to us with a pain score of 10 by 10, and he complains of throbbing pain around the neck for the past 3-4 weeks, and he is unable to sleep because of this pain. So what we did was for immediate pain relief, faster pain relief, we gave him injection morphine, and injection morphine in titrated doses. And this procedure is known as intravenous morphine titration. So how do you do intravenous morphine titration? You have to give injection morphine 1.5 milligram at every 10 minutes interval. Okay. So in Kerala, one ampule, it contains 15 milligram in 1 ml. And for other states, it would be different, but we dilute 1 ml of morphine with 9 ml of normal saline. So total it becomes 10 ml. 10 ml contains 15 milligram, and each 1 ml contains 1.5 milligram. So we give 1.5 milligram of morphine at 10 minutes interval. What is the immediate side effect you are expecting by administering morphine?
Like this.
Which one?
Pruritus and
Pruritus.
and giddiness also patient will be.
Yeah, giddiness. Anything else?
Nausea, vomiting, sir.
Yeah, it is usually nausea and vomiting. So we have to give an antiemetic. Usually we give injection metoclopramide 10 milligram IV followed by injection morphine 1.5 milligram at 10 minutes interval. And how long would you continue to give, or how many doses would you give? How many doses of injection morphine would you give? Or in other words, what is the end point of titration? So the end point is either the patient should have satisfactory pain relief or the patient should develop drowsiness, whichever be the first. So you have to understand that all the pain would not be equally responsive to opioids. Some pain would be 100% may respond 100%, but some pain may be half, some pain may not respond at all. So in such patients, they will have pain, but first the patient would develop drowsiness. So we have to stop there. So while you do intravenous morphine titration, you can make a table like this, which includes the time, pulse rate, respiratory rate, blood pressure, what is the pain score of the patient, is the patient drowsy or not, what is the dose of injection morphine you are given. So this patient who came at 10 a.m., vitals recorded, he says his pain score is 10 out of 10, and the patient is not drowsy, then you will give 1.5 milligram of morphine. You will wait for 10 minutes. At 10:10, you again record vitals. You look for pain score. Patient is not drowsy, then you will give another 1.5. So at 10:30 a.m., when we check, the patient says, my pain score is only 1. I have very good pain relief. So patient is not drowsy also. So this is an indication to stop IV morphine titration. So this patient has received total how many milligrams of morphine? It's 4.5 milligrams, isn't it? So you can do this in an outpatient setting. You need not admit the patient to give intravenous morphine titration. So this patient now has good pain relief, and patient want to go home. So you have to convert this into oral morphine. So what would be the equivalent, or what dose, oral dose would you start for this patient?
Sir, 3 times of IV morphine.
3 times
Oral.
of IV morphine. Yeah. Anyone? Okay. Anybody else? So I would like you to go through this study, which was conducted by Dr. Rajagopal and his colleague, intravenous morphine for emergency treatment of cancer pain, which was published in Palliative Medicine in 2000. And they converted actually intravenous morphine to oral dose in a ratio of 1:1. Okay. And they found that with this conversion, the patients has good pain relief. So I think Dr. Manoj was telling 3 times. In a way, that's right. So when we convert from intravenous to oral dose, we usually multiply it by 3. But that is applicable only when the patient has sustained plasma levels of morphine, which will occur only after 24 hours. Here, we have given only 2 or 3 doses of intravenous morphine in half an hour. And then we cannot expect that there would be enough plasma concentration or sustained plasma concentration of morphine. So that's why we are not multiplying it by 3, rather we are converting the intravenous dose to same oral dose. So this patient received 4.5 milligram. So you can actually start the nearest possible dose. That would be 5 milligram. So 10 milligram tablets are available. So you can give 5 milligram. So morphine has to be given every 4 hourly. Instead of patient wakes up, you can say at 6 a.m. So the first dose at 6 a.m., then 10 a.m., then 2 p.m., 6 p.m., and 10 p.m. But you can see that at 10 p.m., patient is receiving double dose of the normal. Normally it is 5 milligram, but at bedtime, patient is taking 10 milligram. Okay. So why it has instead of 6 a.m. It is written as when the patient wakes up. Usually the patients who have severe pain, they would be sleeping in the morning hours. So don't hold them to take the morphine tablet. Instead, you can wait for them to wake up, and then administer first dose. And next dose should be given from 10 a.m. onwards. And likewise, at instead of 10 p.m., whenever the patient wants to go to sleep, give the double dose. So this is the normal timing. But in addition to normal timing, if the patient has pain, you can administer SOS dose also. It would be the regular dose, that is 5 milligram. Suppose if the patient is taking 20 milligram 4 hourly and SOS dose, then the SOS dose would be 20 milligram. And if you do not have injection morphine, then you have to use oral morphine tablet. If the patient is not on any opioid, such patients are called opioid naive patients. You can start with 5 milligram of morphine 4 hourly and after. If the patient is already on weak opioids like tramadol, then you can start with 10 milligram of morphine 4 hourly and after. So our patient, we started him on 5 milligram of morphine 4 hourly with SOS dose. He is relatively pain-free for the last 2 weeks, but then he needed 3 SOS doses of morphine for the last 4 days. So what shall we do now?
We would like to recalculate the dose requirement. And we will
Yeah.
also incorporate these 3 SOS doses. That means in addition to the 5 milligram QID that the patient is receiving, we'll add 15 milligram more. And then the total dose will divide it by 6.
Okay. Thank you, Dr. Gitanjali. So this indicates that the regular dose is not enough. That's why they are taking more SOS doses. So we have to increase the dose. Okay. So if the patient is taking 2 or more than 2 SOS dose, PRN is same as SOS dose. If the patient is taking 2 or more than 2 SOS doses, then it is an indication to increase the dose of morphine by 30 to 50%. Okay. So this patient, he is taking 3 SOS doses. That is, he is taking total 5 milligram 4 hourly. That means he is taking 30 milligram. And 3 SOS doses means it is 15. So 30 plus 15, it is 45 milligram. So 45 you can divide by 6 and you will get 7.5. Otherwise, you can also just simply convert like this. Whenever the patient requires more SOS doses, increase the dose by 30 to 50%. So 5 milligram, 50% would be 2.5. So 5 plus 2.5 is 7.5. So 7.5 milligram every 4 hourly with SOS dose. But some patients would tell you that it is very difficult to break the small morphine tablet into 4 pieces. So even in that case, 10 milligram would be okay. So we told that in addition to regular doses, we can also give SOS dose. Sometimes even after the patient takes regular doses, there would be pain in between. So the patient would take morphine at that time. So I'm asking you, how frequently we can give SOS dose of oral morphine? Or what should be the time interval between 2 doses of morphine, oral morphine? Okay, for this we have to understand little bit of pharmacology. Yeah, Dr. Abraham says 2 hours, but we'll see. So this is the poppy plant from which we get morphine powder. So actually poppy plant is legally cultivated only in 3 states of India, UP, MP and Rajasthan. And you can see the paddy fields and the seed like thing is known as pod, POD pod. You can see the farmers make small cuts on the pod and this is sap which is coming oozing out from the pod. The farmers will collect it, dry it in sunlight, and then they will transport it into government opium and alkaloid factories in Ghaziabad and Nimuz. And they will make morphine powder from that. And this morphine powder will be transported to various pharmaceuticals and they will make morphine tablet, capsule, injection from this. Okay. And morphine is, after the oral administration, it is absorbed from the small intestine, upper part of small intestine. And it is a, morphine is water soluble. Okay. You can see sublingual, buccal or gingival administration is not usually advised. Some people say sublingual can be given, but the absorption is very, very low. And if some patient claims, I have pain relief after sublingual administration, that means the patient might have swallowed it. And another thing is that if you powder morphine tablet, it is bitter. So whenever you powder, you have to sweeten it with fruit juice or sugar. So this is what happens when you take morphine orally. It will go into the GI tract. Then from the GI tract, it is absorbed into the blood vessels of GI tract. From there to portal vein, from portal vein to liver, where metabolism takes place. So liver is the main site where metabolism takes place. And then metabolites are liberated into the systemic circulation. But minor metabolism can also happen in kidney and GIT, but 90% of morphine is converted into metabolites. And there are 2 main metabolites. One is 3-glucuronide, morphine 3-glucuronide, and the other one is morphine 6-glucuronide. In short form, it is M3G and M6G. M6G is the component which would give you pain relief, but it is formed only in less quantity compared to M3G. M3G can actually produce neurotoxicities. So for this process to occur, it will take some time. It has to go into GI tract, it has to be absorbed slowly, has to go into liver and then metabolize. So by 30 minutes, oral morphine would start to give pain relief, but the peak action would be by 1 hour. So it is always better to wait for 1 hour to give the next dose. So this patient, we increased the dose because he needed SOS doses, and his morphine tablet dose increased to 10 milligram every 4 hours. But patient says it is very difficult to take it every 4 hours. So as doctors, we know that if we are going to take amoxicillin, which needs to be taken 3 times a day for only 5 days, how many of us would complete 5-day course of amoxicillin 3 times? Very difficult, isn't it? So this patient is only asking, will you give it less frequently? What can be done? Yeah, I can see some answers. Yeah, sustained release. So what would be the dose this patient would require? Yeah, I can see 30 milligram SRBD, Dr. Sika. Yes, yeah. So the first one which we talked about, morphine should be given every 4 hourly, was about immediate release morphine or fast acting morphine tablet. Okay, and its duration of action is 4 hours. But there is something called a sustained release morphine or controlled release morphine, and the duration of action is 12 hours. So this patient was taking totally 60 milligram. If you can divide into 2, so you can give morphine sustained release 30 milligram BD. But you have to also understand that this patient can also have breakthrough pain. So in case of breakthrough pain, what would you do? And what would be the dose? It is actually, yeah, 1/6. So this patient is taking 60 milligram total. So you can give 10 milligram, but it is not SR. It should be the immediate release morphine. Okay. So it is morphine, immediate release 10 milligram SOS should be provided along with SR morphine. What are the preparations of morphine available? Aqueous solutions or syrup, tablets as well as capsules, both as immediate release form as well as controlled release form, then injections. So our patient was on 10 milligram every 4 hourly for the past 6 months. He had very good pain relief. But when you are on a casualty duty, this patient was brought to you with excessive drowsiness. And you ordered some investigation and you found out that his total count was 13,000, blood urea was 20 milligrams per deciliter, serum creatinine of 5 milligrams per deciliter. Would you do anything with morphine dosage?
We'll reduce the dose.
Okay. Why should we reduce the dose?
Because the kidney function test, the creatinine is raised. So probably the excretion is impaired in this case.
Okay, thank you, Dr. Gitanjali. So we should understand that morphine is excreted from the body by glomerular filtration. So here the serum creatinine is 5 milligrams per deciliter. That means patient's morphine is not excreted properly from the body. That's why the patient has more drowsiness. So whenever there is renal failure, we should increase the pacing and reduce the dose. Okay. So probably instead of 10 milligram 6 hourly, 4 hourly, you can give it maybe 5 milligram TID or something like that. Or you have to use renally safe opioids. So what are the renally safe opioids? Which opioids doesn't?
Fentanyl.
Which one?
Fentanyl.
Yeah, fentanyl is one. Anything else? fentanyl, methadone, and buprenorphine also. But buprenorphine is not usually used. So this patient, now we reduced the dose because of his chronic kidney disease. We reduced the dose to 5 milligram 8 hourly. And then to your OPD, one of his family member comes after 2 months, and he tell you that the patient is unable to take anything orally, and we feel that he is dying. That's why he is unable to take anything orally. So what would you do now for pain relief?
Fentanyl patches we can use here.
Fentanyl patch. Okay. Any other options?
IV again, IV morphine.
Which one? IV morphine.
Yeah.
Okay. Yeah, subcutaneous morphine, IV morphine. Yeah. But what are the routes through which we can administer morphine? We know that most common route is oral, followed by intravenous or subcutaneous. It can also be administered correctly. Epidural, intrathecal. So for this patient who is at home, what would be the easiest method? Correct, isn't it? So I told you morphine is hydrophilic, that is water soluble. So you can actually take the 5 milligram tablet which you were giving previously, add 2 drops of water, make it a paste, do a rectal examination, and rub it over the rectal mucosa. It will be, the efficacy would be the same as that of oral morphine. Same duration and same dose. And some people consider that rectal route is superior to oral route. Okay. So we would give, this patient was taking 5 milligram 8 hourly orally. So the same dose would be given by rectally. Moving on to another patient. So now we have Mrs. K, who is a 55-year-old lady with carcinoma of the colon who has abdominal pain, which is continuous in nature, and she is on 10 milligram of morphine every 4 hourly, and she says, I have very good pain relief. And as the patient does not want to take it every 4 hourly, the doctor has asked them to substitute morphine with 25 microgram fentanyl patch. And the next day, patient reports to you and tell you that I removed the fentanyl patch after 5 hours, as it was not giving any pain relief. So what would you do now for pain relief?
So for fentanyl to act, it takes 12 hours to get full relief. So we have to continue with morphine at least for 12 hours, tablet morphine.
Okay, thank you. So these are some practical points which we need to remember. All these stories described here are real stories only. So this is one of the patients who came to us. Somebody wrote fentanyl patch, and they removed fentanyl patch after 5 hours. And on questioning, he says there were no pain relief. Okay, so you can see this is a fentanyl patch which has a protective liner, which you will peel off while you apply your body. And you can see that fentanyl is absorbed into the subcutaneous tissue, and there are a lot of capillaries in the subcutaneous tissue. So fentanyl will be at first fentanyl it forms a subcutaneous tissue depot. So there fentanyl would form a subcutaneous tissue storage. And for this storage to occur, it will take about 8 to 12 hours. And from this subcutaneous storage, fentanyl will be liberated into the systemic circulation hourly. Okay. So for the first 8 to 12 hours, the patient may not have pain relief. So you have to ask the patient to continue the previous opioid which he was taking for first 8 to 12 hours, even after application of fentanyl patch. Then only he can stop it and make it SOS. Okay, and all of you know that the duration of action of fentanyl patch is for 3 days. So it need to be replaced every 3 days. And another thing is that whenever you keep the fentanyl patch, you should not shave the area because shaving will produce micro abrasions and the absorption of fentanyl will be increased. And even temperature is another problem which is going to increase the absorption. So patients with fever or you should also advise the patients against taking hot bath or going near the stove. All that need to be eliminated because that is going to increase the absorption. And most importantly, it is not suitable for patients with unstable pain. That means for patients whose pain goes up, comes down very frequently. That means patient's pain is unstable. For such patients, you should not give transdermal fentanyl patch. And patients with post-operative pain, that is only for a short duration. So fentanyl patch is not, it should not be used. So first of all, you have to find out or titrate the pain. Titrate the dose of opioid with. First of all, you have to, if a patient has unstable pain, you have to start him on a short-acting opioid like morphine, immediate release morphine, and find out how much dose of morphine this patient requires to have a satisfactory pain relief. And once you find out that dose, then you convert it into fentanyl patch if necessary. And preparations of fentanyl available are injection, transdermal, transmucosal, fentanyl citrate. So injection and transdermal you would be aware of, but there is something called OTFC or oral transmucosal fentanyl citrate. It is like a lollipop which you have to rub over your buccal mucosa, which will give immediate pain relief. And this would be suitable for patients with incident pain, that is movement related pain. And that is, it has a shorter duration of action also. But as of now, it is not available. Compared to morphine, it is 100 times more potent than morphine. So if you calculate that, this would be the formula. 60 milligram of oral morphine equivalent per day would be equal to 25 microgram fentanyl patch. So please keep in your mind this only so that you can convert any amount of morphine to fentanyl. 120 milligram of oral morphine would be equivalent to 50 microgram of fentanyl patch. So this is how you need to calculate. 60 milligram oral morphine, it is converted to micrograms. Then you have to divide by 24. That would be 25 microgram. Now I am moving on to another patient. Here we have a patient who is on tab morphine 50 milligram every 4 hours. And this patient attends your clinic with severe pain. You have injection pentazocine and oral morphine tablet. How do you manage this patient? Injection pentazocine is, that trade name is Fortwin. So how do you manage this patient? Anybody? Which one would you give? Injection pentazocine or oral morphine tablet?
Initial pentagis or opioid rotation you can do.
Okay, thank you. So for us to answer, we now need to go into a little bit of pharmacology. So what is an opioid? Opioid means it is a drug which produces its action by combining with opioid receptors. That is one. And the other one is its action should be antagonized by naloxone. So when a drug has these two properties, it becomes an opioid. And opioids act on opioid receptors to make many neurotransmitter changes in the dorsal horn of spinal cord as well as in other parts of nervous system. And that's how it gives pain relief. Mu, kappa, and delta are the main opioid receptors. And it can be divided into three according to the action on receptors. One is agonist, and the other one is antagonist, and last one is agonist antagonist. An agonist opioid means it combines with opioid receptors to produce physiological actions. So what are physiological actions of opioids? It will produce pain relief along with other side effects. And most of the opioids, morphine, fentanyl, methadone, tramadol, all are agonists. What is an antagonist? Antagonist acts opposite to agonist. That means the example of antagonist is naloxone. Suppose if I administer naloxone to any of you, what would be the action in your body? It would not have any action because you are not taking any, you have not taken any opioid. So it works only in presence of another opioid. Agonist antagonist means on certain receptors it acts as agonist, and on another receptor it may act as an antagonist. And this is the main difference between agonist and agonist group. So suppose look at this graph on the left hand side where we are giving an agonist opioid like morphine. On the x-axis it is the dose of opioid you are giving, and on the y-axis it is the pain. So suppose you are giving 5 milligram of morphine, you will get this much pain relief. But as you increase the dose of morphine, the pain relief will also increase. And at this point, you will get 100% pain relief. But in case of agonist antagonist, what happens? It will also give pain relief when the dose is increased. But you can see this point, after which, even if you increase the dose, the curve, it flattens. That means there is no further pain relief. That means there is a maximum dose beyond which it will not give pain relief. This means agonist antagonist group of medications have ceiling effect for analgesia. So that's the main difference. Ceiling effect. There is a maximum dose for opioid beyond which there is no pain relief, which is known as ceiling effect for analgesia. So agonist antagonist group of medications have ceiling effect for analgesia. So if you look at the receptor level, pentazocine is a weak antagonist at mu, and it is an agonist at kappa. What is morphine? Morphine is mu
Agonist.
agonist. Okay. So what happens if you give pentazocine to a patient who is already on morphine?
Pain relief will be less. Dysphoria can also happen.
Yeah, pain will be more than giving pain relief, isn't it? Because the morphine from mu would be replaced by pentazocine. And now mu is acting as an antagonist. And the pain relief would be due to agonistic action at a kappa receptor. And important thing is that the opioids which are potent are those which acting on mu receptors. Okay. So pentazocine will replace morphine for mu receptors. And you will have more pain if you give pentazocine to this patient. So you have to find out whether he has missed any scheduled dose of morphine. If so, give morphine. Otherwise, also give SOS dose of morphine because you have only injection pentazocine and oral morphine. I'm not going to talk about methadone in detail, but methadone is another medication or another opioid which is available in India since 2017. And you can see methadone is a particular or a special opioid in the group of opioids. It has multiple mechanisms of action. You can see it is a isomer of S-methadone and R-methadone, and it acts on all the receptors, all the opioid receptors as agonist, mu, kappa, and delta. It is also an NMDA antagonist, so it acts like ketamine. It also inhibits the reuptake of noradrenaline and serotonin. So it acts like a tricyclic antidepressant. So there are three mechanisms of action which makes methadone a special opioid to use in various situations. So those three are beneficial effects of methadone. But there is another problem. You can see below. It blocks human either A-go-go related gene channel. That is HERG, human either A-go-go related gene channel. When it is blocked, it will increase the QT interval and can lead to torsade points and to sudden death. So this is one of the feared side effects of methadone, but this is very, very uncommon with the type of dose that we are using for pain relief. Okay, if you are going to use less than 50 milligram of methadone per day, the chances of prolonged QT interval and torsade points are very, very less. And another important thing is that morphine can be increased every day if you want. But for methadone, you have to wait for 5 to 7 days before you increase the dose. So this is another important point. And it is excreted mainly through bowel. And there is a supplement on methadone in Indian Journal of Palliative Care, which was published in 2018. There are, I think, 6 or 8 articles which you can see if you are interested about methadone. And this is another paper, Safe and Appropriate Use of Methadone in Hospice and Palliative Care, Expert Consensus White Paper in 2019. This is another good research. And what are the indications of methadone? If the patient has opioid toxicity, if the patient is on other opioids and if they have opioid toxicity, if the patient has complex neuropathic pain, if the patient has opioid-induced hyperalgesia or tolerance, if the patient has pain and has chronic kidney disease and allergy to other opioids. And this is the conversion according to the consensus method. In patients who are opioid naive, you can start with the 2 to 7.5 milligram of oral methadone per day. And if the patient is taking less than 60 milligram of oral morphine per day, 2 to 7.5, 60 to 199 milligram. If the patient is taking oral morphine equivalent between 60 to 199. And if the patient is less than 65 years old, the conversion ratio is 10:1. That means suppose the patient is taking 100 milligram of oral morphine, then you have to divide it by 10. So that would be 10 milligram of methadone. To start, you have to use 5 milligram PD. And the duration of action of methadone is 8 to 12 hours. 8 to 12. And if the patient is taking more than 200 milligram of oral morphine, and or bar if the patient is more than 65 years, the conversion is 20:1. Okay. And even though the ratios are like this, never start the patient on more than 40 milligram per day. Okay. And this is what is available. Tablet, that is 5 milligram, and syrup, it contains 5 milligram in 1 ml. So I am going on to adverse effects of opioids. What are the adverse effects of opioids? We can divide adverse effects into two: side effects and toxic effects. So what are side effects? Side effects mean these are the adverse effects with therapeutic doses. So what are adverse effects? Can anybody tell me what are the adverse effects? Side effects? What are the side effects of opioids? Yeah, nausea, vomiting, constipation. Yeah. So constipation, nausea, vomiting, sleepiness, and tiredness. These are the common side effects. And there are minor side effects: itching, dry mouth, urinary hesitancy. And what is important about constipation? It occurs in almost all patients if you start them on opioid. And the constipation will be there as long as the patient is on opioid. So you have to give the laxative continuously till the patient is on opioid. And the drug of choice would be stimulant laxative. Example is bisacodyl, sodium bicosulfate, or senna. Nausea and vomiting, it occurs in almost 1/3 of the patient, but tolerance develops to nausea and vomiting. So for the first 3 to 5 days, you have to give an antiemetic. After that, you can stop. And it is mainly due to stimulation of chemoreceptor trigger zone in the brain. And these are the medications which would be most effective for opioid-induced nausea and vomiting: haloperidol and metoclopramide. Because CTZ contains dopaminergic type 2 receptors, and haloperidol and metoclopramide are the drugs which blocks dopaminergic type 2 receptors in the brain. Sleepiness and tiredness. This also occurs only during the first few days. Then tolerance develops. So you need not do anything. It is self-limiting. So another adverse effect is toxic effect. Toxic effect means it is the adverse effect when the administered dose is higher than the required for pain relief. Okay. And it is manifested by delirium, myoclonic jerks, and extreme drowsiness or undue drowsiness. Delirium, myoclonic jerks, undue drowsiness. These are the toxic effects. So if the patient has toxic effects, that means you have to skip 1 or 2 doses of morphine, and then you have to reduce the dose. And what about this opioids producing respiratory depression? What's your experience? Not likely. Dr. Shiga says not likely. In overdose. Yeah. So this is a systematic review from 2003, which talks about oral opioids It says patient takes their medication by mouth. Combined with normal gradual increase in dose ensures that respiratory depression is unusual. And it continues to say that if there is respiratory depression, you should look for any pneumonia. Is this patient having pulmonary embolism? Is there cardiomyopathy? Or are you co-administering any benzodiazepines along with opioid? Okay, so respiratory depression is very unusual. What about this addiction? No?
If you're giving the opioid for indication like pain, then we cannot call it addiction.
Not very clear, Dr. Abraham.
So if you're giving it for a specific indication like pain, then if the patient takes morphine, we will not call it an addiction.
Okay. So if you prescribe opioids for medical purpose, then the chances of addiction is very less. What is addiction?
So if there is already history of taking some drugs or some of smoking or some other drugs, there are chances of addiction.
Okay. Anybody? What is addiction?
If not given, the patient gets withdrawal symptom. No, that is addiction.
Okay. So
Monitoring is impaired control over drug use. Means patient compulsive user of something.
Dr. Sika, I think
Is there for opioid.
there is echo from your end. Have you logged in from 2 devices? So I will give you an example. Many of
It is
you,
basically craving or compulsive use of drug. That is addiction. In spite of knowing it can cause harm.
okay. So I will give you an example. Many of you would be taking coffee in the morning. Suppose one day there is no coffee because there is no coffee powder and sugar. What would happen to you? How is it going to manifest? Headache, yes. Yawning? Irritation? Is it addiction? Yeah. Everybody is very much experienced. Is it addiction?
Yes, it can be said.
Yes. So how many of you have addiction here? Yeah. So what I would say is that is not addiction. That is physical dependence, which is manifested as withdrawal reactions. If you have addiction, then what would you do? You will break into the neighbor's house where coffee powder and sugar has kept, and you will get it anyway. That if you do that, that would be addiction or psychological dependence. But the other thing, even if you don't get coffee for one day, you will not do anything. You would, okay, next day morning I will have coffee. I can get coffee powder and sugar. You would not break into the next house. So that's the difference, simple difference. I am making it too simple. So that's the difference between physical dependence and psychological dependence. Whereas psychological dependence is known as addiction. And this is the definition by American Academy of Pain Medicine. They say addiction is a disease in genetically predisposed individuals, and psychosocial and environmental factors influencing its development and manifestations. So that means if you have a gene for addiction and if your environment becomes favorable, that means some of you might be working in operation theater where opioids are freely available and one of your friend is misusing this. So all the environment becomes favorable, and in such condition, as you have a gene, you may get addicted. So they say it is a genetic disease, and you can see there are so many things by which you can understand the patient has addiction. And I just want to show you one thing more. This is something which you should understand: the comparative prices of opioids, because pharmacoeconomics is something which everybody should be aware of. Then only we would be able to help our patients. So suppose a patient is having pain and with 5 milligram of morphine every 4 hourly, you are controlling that pain. Patient has good pain relief. So in that case, the patient need to spend only 3 rupees 50 paisa per day. But to get the same pain relief with tramadol, they have to spend 24 to 50 rupees. With fentanyl patch, 250 to 400 rupees for 3 days, And buprenorphine patch, it is even worse. But with methadone, it's almost comparable. So please keep in your mind, even if you prescribe some costly medication, the patient may not buy it. And they may continue to come to you telling that I have no relief. And maybe they may not be actually able to afford it, and they may not be taking it. If you prescribe pregabalin, gabapentin, which are very costly medication, they may not buy it. So this is another important aspect, which is also one of our duty. Okay, I think I will stop here and would take questions if there are any.
Dr. Sunil Kumar, will these slides be made available to us?
I think yes.
Yes, definitely. They will be uploaded to IECO from where it will be accessible to all of you.
At the end of the lecture or at the end of the course? Will it be available like today?
There would be like a cooling period of 3 to 4 days.
Okay,
So
thank you.
today, the last 2 session slides will be uploaded today. So as
All
and
right.
when it becomes available from the faculties, we will upload it. And once
Thank
it
you
is
so much.
uploaded, we will intimate in the group that
All
the
right.
slide has been uploaded so that you can start accessing.
Thank you.
Any questions from the participants? Especially the session is on opioids. So if you have any questions or clarifications needed, please feel free to ask Dr. Sunil.
Dr. Sunil Kumar, I do have a question on the very first patient that you had, the lung cancer patient with throbbing pain, pain of 3 out of 10, and we were, giving him paracetamol 750. My question is, we went directly from that to tramadol or tapentadol. Why did we not go through any type of adjuvants? Is that because it was visceral nociceptive pain that's not as responsive to the adjuvants, or I couldn't understand why we skipped the adjuvant part and went to tramadol?
Yeah, thank you, Dr. Sudha. In that patient, first step, that is non-opioid plus or minus adjuvant. So adjuvants can be used if indicated. So usually the adjuvants would be tricyclic antidepressant, anticonvulsants, corticosteroids, which I think would not be beneficial for this patient. So that's why without adding any adjuvant, we went on to the second step.
All right, thank you.
Sir, I have a question regarding the a prescription of opioid, prescription of morphine tablets. Because a lot of times patients comes from a distance, and they say that they cannot come every week, once a week. And a lot of times they say, that we'll be coming after 2 weeks or 3 weeks. And for example, if there is a patient who's on 20 milligrams sustained release tablet,
Yeah.
and this patient is, receiving 2 tablets per day. So is it okay if we hand over, 28 to 30 tablets to this patient?
Okay, that's a very good question. Where are you from, Dr. Gitanjali?
Sir, I'm at UCMS in GTB Hospital.
MCMS?
UCMS in Guru Tegh Bahadur Hospital, Delhi.
Delhi. Okay. So, you know that the stocking, dispensing, all those are governed by, of opioids are governed by NDPS Act, Narcotic Drugs and Psychotropic Substances Act. But according to that, they do not give any direction for how many days it should be given. So, but at the same time, it's also our responsibility to make sure that patient uses opioid properly. Because you know about the opioid crisis that has happened in USA. But in India also there is opioid crisis. But that is not because of here there are a lot of opioids. It is because the other extreme. In USA there are a lot of opioids available to everybody. I think the per capita consumption is more than 300 grams per 300 grams. But in India, the per capita consumption is only 0.016 milligrams. So that's the difference. So, but we also have to balance this. So maybe in our practice, we usually give opioids up to 2 weeks for patients who are nearby. But if they are coming from long distance, maybe even 1 month, we usually provide. And during COVID times, we actually provided for 6 weeks because it would be very difficult for them to get the supply of opioids. So there are no direction, but 1 month should be okay.
Thank you, sir.
Sir, I have a question regarding the absorption of morphine. Does food play any role with the absorption of morphine or like this?
Question is not very clear.
Sir, I think does the food plays any role in terms of absorption, intake of food?
Okay.
That's what I understood.
Yeah. There is no much a role for in absorption with food. So it is safe to be administered even before food or after food.
So buprenorphine patch, I wanted to ask.
Yeah.
Your experience about buprenorphine patch.
As much as possible, we do not use buprenorphine patch. We use morphine and methadone, and very rarely fentanyl patch. The buprenorphine, one thing is that it is very costly and titration would be very difficult. But people with non-cancer pain, then some people use buprenorphine patch. Yeah.
Thank you.
I was about to continue. Dr. Ahmed was asking about food intake and the absorption. I think the first dose of morphine usually comes as soon as they get up in the morning. So sometimes patients will ask you, do I need to have food before taking this tablet? So you need to tell them that it is not going to cause any. People generally relate taking tablets and gastritis or acidity. So you can tell them you can take the morphine as soon as you get up. Otherwise, they will wait for having breakfast, then by that time the pain might have started and that will be difficult to control later. So there is another question in the chat regarding the use of opioids in kidney failure,
Yeah, I
in
saw that.
hepatic failure. Yeah.
So this is very controversial in terms. If you look at the articles, they all give different opinions. But usually, in case of renal failure, you might use methadone and fentanyl. And if you need a weak opioid, tramadol. But if the patient has CKD stage 5, that is ESRD, end-stage renal disease, the maximum dose that you can use is 100 milligram per day. In case of patients with liver failure, in case of morphine, if it is not severe liver failure, you can use in chronic liver diseases. You can use morphine normally, just like in a normal person. But if the liver function is completely altered, if there is severe liver failure, then you have to reduce the dose of morphine. Methadone is also like that. So the doses of methadone, and even some people advise that if there is severe liver failure, then methadone may cause toxicities. So it may be better not to give methadone in case of severe liver failures.
Any other last question before we wind up? If there are no more questions, maybe we can wind up today's session. Thank you so much, Dr. Sunil, for the case-based discussion on opioids. I hope that was helpful for everyone, and we hope you will start treating your patients with the appropriate analgesics without any restriction or phobia to any of these analgesics. Thank you so much, everyone. Over to you, Shripriya, for closing the session.
Thank you. Thank you, Dr. Sunil. Thank you so much. And thank you everyone for joining. Before we wind up, just a small piece of information, if anyone could find it useful. Since I'm a non-medical person, and since I could feel that many of you are much interested in knowing more about pain management and all, we do have a series of programs in our institution which are self-directive. You can spare your own time at your own convenience and learn more about pain management. More extensive courses are there, starting from a 2-month course to the extensive 1-year course in palliative medicine. So in case someone is interested, please do feel free to drop us a personal message. We are definitely willing to help you out. With that note, this is Shripriya along with Dr. Sunil Kumar and Dr. Sridevi signing off from the Tips. See you tomorrow, same time. Till then, everyone take care. Bye-bye.